Oh, okay. There we go. I think you can unmute now.
Thank you. And I can't share my screen at the moment.
Oh, let me see if I can.
You have to make her a host, Kat.
Okay. Just a moment. I'm sorry. I'm not the best with Zoom.
That's okay. Yeah, I think you've just got to, maybe it's, not sure.
Does that work now?
Yep. Can everybody see that?
Yes.
Okay, let me just. Fantastic. All right. So I'll get started. So just a quick background about me. So I'm a principal research fellow and I'm a clinical neuropsychologist. So that means we're psychologists who specialise in brain function and anything that affects the brain and then how that impacts cognition. So thinking skills, emotions and behaviour. And that's kind of and I in particular specialise in mental health and in youth mental health in particular. So Origin is a youth mental health organisation, and most of my research has actually focused on psychosis, so early psychosis and a bit of depression. And I have to say I haven't done a lot of my own research in bipolar disorder. Just a little bit of work in first episode mania, supervising a PhD student who did some work in that area. But I guess you could say that my expertise is in cognition and how cognition is impacted in mental health conditions. As I said, with a particular focus on youth, but I have a strong interest in the trajectory of cognition. So what happens to cognition over time, over the lifespan in relation to mental health conditions. And so when the paper that you've asked me to talk about was a commentary that I wrote with Dr. Tamsin Van Reenen, who's also at the University of Melbourne. And we wrote that, we were invited to write that commentary as I'll show you some data of some recent reviews which have shown that cognition is quite stable over many years in people with bipolar disorder. And so we wrote a commentary to say that it's not as simple as that, and that it is quite complex to understand, and that there are different factors that we need to take into account. So I was really touched that you invited me to present on this commentary. And so what I've done is I haven't actually gone into a lot of detail about the commentary because it's a very short piece. It was only 2 pages. But I've taken the liberty to present you with a bit of background on what the current state of evidence is around cognition in bipolar disorder. And I'm very conscious of the fact that my experience is as a researcher, so I can share with you my knowledge and expertise about the research and what the research shows. But other people bring different expertise, and my understanding from Kat is most of the members are people with bipolar disorder or lived experience of bipolar disorder, or their families, or they know somebody with bipolar disorder. So I imagine you will bring a completely different, you bring a different level of expertise, and so I'm quite keen to hear about your experiences as well, because together, somehow that we can find the truth, I guess, of what the experience is for people. So hopefully you find this interesting. I'll try not to take too long so we have time for discussion. And if it's okay, how does this normally run? Do we normally do questions as we go, or do I present and then we have a discussion at the end so that it flows?
At the end, so
yeah,
no interruptions.
Yeah, That might make it flow a bit quickly and smoothly, yeah. But I can always go back to slides if you have questions at the end. We can go back to particular slides. So I'll get started. So yeah, lovely to meet you all, and it's a real honour to be here and present today. So this is the overview of what I'm presenting. So what do we know so far? I'll give you a background about what we know about cognition in bipolar disorder. Then I'll just talk about, in our commentary, we raise sort of 4 key issues. They're not the only issues, but 4 key issues that we need to have get a better handle on to really understand cognitive functioning. So heterogeneity, the role of relapse, episodic relapse on cognition, the length of the follow-up of the studies that have been conducted to date, and also the effects of medication. So that's what I hope to cover. Now, I'm not making any assumptions here about people's knowledge. So I hope I'm not, giving you information that's totally obvious, but I thought it might be good just so that we're all starting from the same baseline level of knowledge for the talk. And so I'm just briefly explaining a few concepts in research. So you may have heard of a meta-analysis. So I'll be presenting some data from a number of meta-analyses that have been conducted. And a meta-analysis is a form of statistical analysis that combines the findings of several scientific studies that have investigated the same question, and they combine it into one big analysis. So a meta-analysis is considered a more precise estimate of the strength of the evidence than just one individual study. So it combines, several studies that, for example, that have looked at cognition in bipolar disorder and gives an estimate of the effect. And it's considered more precise than just one study alone. And the effect size is the statistic or the metric that we use to interpret the strength of the effect. So how strong is that effect? I'll be presenting a couple of meta-analyses to you today. The effect size, just to go into a bit more detail, as I said, it's a metric for quantifying the size of the effect. So for example, if you're comparing people with bipolar disorder with people without bipolar disorder, you can quantify what's the size of the difference on a particular measure. And so in our case, we'll be looking at cognitive functioning and how to interpret the effect size. So what we know is that if we have an effect size that's around 0.2 or smaller, that's considered a small effect. Whereas if the effect size is at around 0.5, it's a medium effect. And then anything at 0.8 or higher is a large effect. So that's, the larger that number, that effect size number, the larger the effect and the larger difference between the groups. So hopefully that kind of gives you a bit of metric to understand the data that I'm presenting. So let's start with what we know. So I'm not presenting, there have actually been a number of meta-analyses, like multiple meta-analyses of cognitive functioning in bipolar disorder, and they've been conducted at different stages of the lifespan. So they've been done in children and adolescents, they've been done in early adulthood, they've been done in the elderly, middle age, they've been done in euthymic stages, so when in between episodes when people are stable. They've been done at all different stages of the illness and also of the lifespan. But what I'm presenting to you here is, what do we know about cognition right at the start? So when someone has a first episode of bipolar disorder, which is normally defined by a first manic episode, so following their first manic episode. And this is a meta-analysis of 15 studies. So they've combined 15 studies together to look at what's the effect. And down the bottom of the graph, it lists different cognitive domains. So you can see premorbid IQ, PS stands for processing speed, verb the next one is verbal memory, then visual memory, reasoning, then WM means working memory. Fluency is how the flow of language and how easily it is to say words quickly, and attention. So they're just different cognitive domains that we assess as neuropsychologists. And then along the side is the effect size. And so what this is showing you is the difference between people with bipolar disorder at the first episode compared to healthy controls, so people without bipolar disorder. And I just put the little graph on the side to remind you of what the effect size means. But basically, in summary, what this is showing is across all of these cognitive domains, people with bipolar disorder at the first episode are more impaired or have poorer cognitive functioning compared to healthy controls. And you can see the largest effect is in attention, so being able to focus and concentrate, whereas the lowest effect is in pre-morbid IQ. So, but there's still a small effect there. So you can see it's just above 0.2. So it's still significant. It's still significantly different from healthy controls, but a smaller effect. So you can see how different cognitive domains are impacted to different degrees. So hopefully that's making sense. So I think, I can't remember if it was Denise or who mentioned before that they might be speaking to their psychiatrist about this, that, there's evidence from the outset that people do experience cognitive difficulties from the start. So, but I did just want to talk to you a bit about pre-morbid functioning. So there has been a bit of work done on whether cognitive difficulties or academic difficulties are a risk factor for bipolar disorder. So could it be that, cognitive issues are there even before the illness has its first onset? And that's still an area of debate, I have to say. So there's still a lot that we don't know about that. And that's partly because it's really hard to do studies to capture people early enough in life before they start to experience symptoms. And because many of you may know that the period before diagnosis can be quite a long time. And so it's often hard in research to capture people early enough to know if there were cognitive difficulties prior to the illness. But this was published a few years ago now in 2010, a cohort study of Swedish, they linked up data of people living in Sweden and looked at their academic performance at age 16, and then looked at whether academic performance at age 16 was a predictor of experiencing bipolar disorder later in life. And what they found, which was real, and so on the left column is people's risk for developing schizophrenia, and on the right is people's risk for developing bipolar disorder. And what you can see for bipolar disorder is it's a bit of a U-shaped graph there, and it shows, so GPA is grade point average, and so if somebody is scoring 0, which is in the middle at the bottom, 0 means they're no different to average. Anything like -2 means they're more than 2 standard deviations below the average in their grade, so they're performing more poorly academically. And then anything over, like +2, means they're performing much better than the rest of their class in terms of their grades at age 16. And what this graph shows is that people who are performing more poorly academically, so more than 2 standard deviations below average at age 16, are 2 times more likely, have a twofold increased risk of developing bipolar disorder later in life. But really interestingly is that actually if you're performing above the class, so more than 2 standard deviations above the class in terms of academic performance, your risk of developing bipolar disorder is 4-fold. So there's a bit of a bimodal risk there. So either performing much lower in class or even better than the average student. Increases is associated with an increased risk of bipolar disorder. This is really different to the pattern we see in schizophrenia, where you'll see on the left, I didn't do any little circles, but basically if you're performing much better than the rest of your class, it's actually protective against developing schizophrenia later in life. So so really there's more of a linear relationship, that the poorer you're going in school, the higher the risk of schizophrenia later in life. Whereas bipolar disorder is quite the opposite, where if you're either performing low or high, that increases your risk. So what that tells us is there's significant heterogeneity, so much more a mixture in terms of risk later in life, and that cognitive functioning might be really variable, even right at the start in people with bipolar disorder. Next page. So the current debate that we have is, one of the current debates that's going on in the field at the moment is whether the multiple manic or depression episodes are associated with progressive decline in cognitive function. So there are researchers in the field who would argue that it is, that, the more depressive or manic episodes that people have over their life, the more likely they are to experience cognitive decline over time. So, but that's still up for a debate. And what that is based on is mostly cross-sectional studies. And cross-sectional studies, what they do is they measure someone's cognition at a certain point in time, and they ask the person, how many episodes of mania or depression have you had in your life? And then they draw a correlation between the two. But the problem with cross-sectional studies is it could be reverse causality, where it might be that people with a more severe form of the illness have poorer cognitive functioning. So it might be that someone, who has a more severe bipolar disorder is also destined, or was also going to have poor cognition to start with. So cross-sectional studies don't really tell us about what happens over time in a really accurate way. It only takes a snapshot of information at one point in time, and they're related. It's saying that the number of episodes and cognition are related, but it doesn't say how they're related and whether there's a change over time, or whether people with a more severe illness have more severe cognitive impairments. So that's a real debate in the field at the moment. So we need good longitudinal studies to help us answer that question. So longitudinal studies mean assessing cognition multiple times, repeatedly over several years, so we can track what happens to cognition over time. So in the next set of slides, I'm going to show you some meta-analyses which have looked at that question, where they've combined studies that have tracked people over time to determine, do we see a progression of cognitive decline over time in the illness. So this meta-analysis came out in 2017, and these authors combined 19 studies, and their inclusion criteria was that the study needed to follow up people for at least a year. So they had to assess them at least once at baseline, and then again at least a year later. And in the end, of all the studies that they included, on average, people were followed up for 3.7 years. And so again, this is a really powerful way of combining the existing data and having a precise estimate of what's going on. So 19 studies were combined here. And how you read this, this one's presented a bit differently to the previous slide I showed you. But basically, down the bottom, what I've circled is the overall effect size. And you can see that it overlaps with 0. And if it overlaps with 0, it means that there's no difference between the first assessment and the second assessment. So if that diamond at the bottom was shifted much more to the right and not crossing the 0 line, that would suggest that people's cognition improves over time. If the diamond was shifted to the left and not crossing the 0 line, that would suggest that people are experiencing a decline in their cognition. But what we see is that isn't happening. So you can see that all the studies, if you look above, all of the studies vary quite considerably. So they all kind of have their own individual effect size, but the meta-analysis combines those all together. And what it shows is that people's cognitive functioning stays pretty stable, at least over a mean of 3.7 years. And this is in people in adulthood. So all the participants in this study were adults. They did range from early 20s right through to 60s. So it does cover a wide age range, but generally there was the conclusion from this study that cognition is stable, at least over the short term, over the first few years, or not first few years, at least over a few years of follow-up. Then more recently, so the next meta-analysis that I'm going to present is the one that I wrote the commentary about, so the one that prompted me to write this commentary. So I'll share those findings with you. So more recently, in 2020, Schmalwitz, I think you might say, they looked at whether they decided to combine studies that were either conducted within the first 2 years of diagnosis, so in recent onset bipolar disorder, and then they also combined studies that examined cognitive change in later life, so sort of in people who are over the age of 50. So they wanted to extend the meta-analysis from the previous one that I showed you to sort of see whether, well, maybe the change in cognition, or if there is a decline in cognition, maybe it happens earlier in the course of illness, or maybe it happens later in life, and we need to hone in on those particular periods in a bit more detail. So what they did in this meta-analysis was focused on those 2 periods. So this is, and you can see there's much fewer studies that have been done, and the follow-up was shorter. So this is looking at cognition in recent onset bipolar disorder. So, and their criteria for recent onset was that people had to be diagnosed within 2 years. So relatively recently. And they had to have a minimum of 1 year follow-up. And most of these studies followed people up for 1 to 2 years. So still, I would consider still quite a short period of time. So what they found, the top panel is studies that combined changing cognition in people with bipolar disorder to changing cognition in healthy controls. And then down the bottom is all the studies where they just looked at changing cognition in only people with bipolar disorder. So again, you can see that the findings are very similar to the previous meta-analysis, where the overall effect size, which is that light blue diamond, is crossing 0. And when it crosses 0, it means it's not significant. There's no significant, so the top panel is saying there's no significant change in cognition over time between patients and controls, that they both have the same trajectory or same pathway of cognition over time. So patients, so I should clarify, people with bipolar disorder still perform more poorly than controls, but over time that remains stable. So that difference between the groups remains stable. So you're not seeing a decline in the bipolar group and a stability in the controls. Again, so you're seeing a stability of their cognitive function. And then the bottom panel just shows the same thing. Again, it just looks at patients over time without taking into account the healthy controls. And again, if it's to the right, it's more likely to be an improvement. And if it's to the left, it's a decline. But overall, you can see that it's crossing 0. So it's considered a very stable cognitive course. this is within the first 2 years of diagnosis. What about in later life? So you can see that this is only 4 studies, so much less research has been done in people over the age of 50 and looking at their cognitive functioning over time. But the follow-up period is longer, so the average in these studies was 3.3 years follow-up. And again, it is again showing relative stability, although there's a lot more variability there. There's one study you can see by Guild and Gers, where they actually did show a decline over time. But when you combine all the studies that have been done, it comes out as not significant. So the effect size is non-significant. Maybe it's slightly leaning towards decline in older life, but I'd be very, very cautious in making that interpretation because it's based on fewer studies. So the fewer the studies, the less confident you can be in the result. And really the conclusion is we need more studies. But I guess the take-home message from what we know from the literature at the moment is that the studies that have been done when they're combined in meta-analyses at different phases of the lifespan, at different phases of the illness, is we're seeing relative stability. So that's kind of the first kind of take-home message. But I guess what I wanted to then unpack is, well, what are the factors that we need to think about to better understand people's individual experiences, because we know that that's really variable. And, you know, studies such as these combine everybody into one group. And obviously that then masks individual variability. So let's discuss some of the issues. So these are some of the things we raised in our commentary. So the first one is that we know one size doesn't fit all. There's considerable heterogeneity in cognitive functioning in people, in anybody, in people with bipolar disorder, in people with schizophrenia, in people with depression, in people without mental health conditions. We all vary in our cognitive abilities. So how can we understand that a bit better? So as I said, these longitudinal studies, these follow-up studies have looked at cognitive trajectory in a single group of people with bipolar disorder. So they've lumped them all in together, and this is what they've found. But we now know that there's evidence for cognitive subgroups with multiple, from multiple cross-sectional studies. So a number of studies have been done now that have tried to use statistical methods to cluster people into subgroups that are more similar. And what these cross-sectional studies have found is that there tends to be sort of 3 subgroups: a group who do really experience severe cognitive impairment, a group with selective, or like maybe selective, I mean, people might experience difficulties in one cognitive domain but not another. So they might have some memory difficulties, but you know, their problem solving is fine, for example. And then there's a group of people who have what we would consider preserved cognitive abilities. I'll show you a graph in a moment to illustrate that. So a number of cross-sectional studies, so where they've assessed people at one point in time, have found these subgroups. But what we don't know is then what happens over time. So are those subgroups replicated over time, or do they change over time? For example, do people who have preserved cognitive abilities at the start, are they more likely maybe to experience decline because they started from a higher level, for example? We don't know the answer to that. So we do need longitudinal studies with larger sample size and investigate these possible subgroups over time. And so far, nobody has done that in the research space. So I'll just show you, this is what the cross-sectional study of cognitive clusters looks like, or cognitive subgroups. And so what you can see is, so the Z score again is sort of like an effect size. So anybody at 0 means that they're performing at the same level as healthy controls. So if you're above 0, you're performing better than healthy controls. And when I say healthy controls, I mean people without bipolar disorder. And then below 0, your people are performing below healthy controls. And using cluster analysis, which is a statistical technique to try to group people into more homogeneous subgroups, we find 3 subgroups. So around 32% of people fall into the intact group, and by intact, we just mean that they're not significantly different from people without bipolar disorder. And then there's a selectively impaired group, which is the group with the little triangles, the grey triangles, where in some areas of cognition, they're having some difficulty, but in other areas of cognition, they're not. So for example, visual learning, they're doing really well. So you can see sort of a bit of variability there. And then there's a globally impaired subgroup who are having difficulties across the board in most cognitive domains, quite a bit lower than healthy controls, and kind of performing at a similar level to people with schizophrenia. So in this study, they just included that schizophrenia line as a comparison point. But I take that sort of with a grain of salt because they were sort of taken from separate studies. So you've got to be careful when you do that. But you can see that people, when you do this type of analysis, people fall into different subgroups rather than everyone being lumped into the one group. And what about relapse? So again, the longitudinal studies that I showed you in the meta-analyses weren't easily able to take into account the number of relapses people might have experienced over time, and whether that had an impact on their course of cognition. So those longitudinal studies really look at length of illness, but they don't really look at within that 1 to 2 years. There's some people who are well and have no mood relapses. But then there's people who have lots of relapses in that 1 year. And we haven't really teased that out particularly well yet in understanding that role of relapse and whether it has a negative impact on cognition over time. Oh, I noticed that someone was waiting to get in. So, sorry. So a recent study by Sanchez-Morla actually looked at that question, and they followed people with bipolar disorder up for 5 years. It was a really good study, where they assessed people only twice. They did a cognitive battery with them at one point in time, and then they did a cognitive battery with them again 5 years later. And they specifically looked at that question about the role of relapses on cognition. And what they found really interestingly, that as a group, when they looked at the group as a whole over the 5 years, there was no change. Cognition was stable in the whole group. But then when they compared people who they broke them into subgroups, and they looked at people who had only one relapse versus people who had more than one episode, manic, and in particular, they looked at depression episodes and hypermanic or manic episodes. And they found that people who had more than one hypermanic or manic episode in the 5 years did show decline in global cognition, working memory, and visual memory. So when they separated those people out with more relapses, and particularly manic or hypermanic episodes, they did seem, their cognition seemed more impacted than those who'd only had one episode or less over the 5 years. And it was specific to mania and not depression. So this was one of the first studies to do that, and it's still very recent. So there's more to be understood, and we don't know what the mechanism is. There's a number of hypotheses around that, but this is where research is becoming a bit more sophisticated and trying to drill down and understand individual experiences a little bit more and take the course of illness into account. There's also research, not from the Sanchez-Morla study, but other research that's been done to show whether psychosis has an impact. And there's definitely evidence that if people have experienced psychotic symptoms or psychosis in relation to their mania, that they also experience worse cognition. But the impact on the trajectory, like whether it causes a decline over time, is unknown. We don't know that. And so it is still difficult to know if the episodic relapse causes cognitive decline or whether relapse and decline are related to some other factor. So maybe they're both a byproduct of something else, another factor that we need to measure or to understand better. It could be treatment effects, it could be medication that works together in affecting, who knows, relapse and cognition, or environmental factors, or even genetic factors which have some predetermine people to having more relapses and cognitive decline. We still don't know, so there's a lot to understand there. And you've probably already picked up that I've kind of made a note of the length of the follow-up periods of the previous longitudinal studies, and mostly they're fairly short. Apart from that 5-year follow-up study that I just presented, most studies only follow up people for 1 or 2 years, which is really not long enough to understand what happens to cognition over time. There are studies, so most are 6 years or less, but as I said, most are even shorter than that. There was one in 2012, the longest follow-up study to be conducted was a 9-year follow-up study, and they did show decline in one domain of cognition. So they assessed a range of cognitive abilities and mostly found stability over the 9 years. But there was one domain, and that was cognitive flexibility. So being able to problem solve and think about different solutions to a problem. They did find that there was a decline over the 9-year period, but it was hard to interpret because as you've probably picked up, you do need a comparison group to know whether is that normal part of aging? Is that just because they're getting older? Or is that specific to having bipolar disorder? And the only way to answer that question is to have a comparison group of people without bipolar disorder, but ideally you'd also want a comparison group of people with other mental health conditions to know, how specific is this to bipolar disorder, or does this happen to everybody who experiences a mental health condition? So that there's more to be done there as well. So we really do need longer follow-up studies, so 10 years or more. Cognition is a pretty, we know generally that people's cognitive functioning is actually quite a stable trait. It's, we know from a young age as children that, when you're at school, you know who the smart kids are and who the ones who struggle in class are and who are the ones who are kind of average and sit around the middle. And that actually is quite a stable trait of a person, their cognitive function. And so to really understand the impact of a brain condition on cognition, we do need to assess it for a much longer period of time to look at the impact on cognitive function, because cognition is a pretty robust ability. And so that we do really need to understand what happens over longer periods of time. They're really hard studies to do, but really important to understand the impact on people who are living with the condition. What about medication? Now, I'm not a psychiatrist, I'm not a doctor, so I'm not an expert in the medication side of things, but I thought that you might be interested in a little bit about the literature. And I guess the first thing I'll say is it's incredibly mixed and controversial, the effects of medication on cognition. And I would say highly individual. So people respond to medications in such individual and unique ways, and in terms of the side effect profile and other things. So I think it's really important to just keep that in mind. The other thing we know is that when people are unwell, acutely unwell, their cognition is poorer when they're experiencing a high degree of symptoms. And so medication, effective medication will reduce the symptoms, which will improve cognition in the short term. So there's definitely evidence for that. But what we don't know much about is what are the impacts of cognition during the euthymic phases. So when people are well, their moods are going along well. What happens over the longer term in between episodes? How is cognition impacted? So it's really important to consider that question. So lithium, there's lots of mixed findings. So some people report, and there's evidence showing mental slowing, but there's also some positive effects as well. There's people who are excellent lithium responders. So people who respond really well symptomatically to lithium also tend to show better response in terms of cognition. And there's also some research showing that for people on lithium, there's a lower risk of dementia later in life and Alzheimer's disease. So there are a number of medical professionals who are proponents of the neuroprotective effects of lithium and talk about it as a protectant of the brain and of cognitive functioning. But I would say there's still a lot more research to do in that space and to understand that. And then I'll just do these ones quickly because I'm aware of the time. So a range of other medications that are commonly prescribed in bipolar disorder. And again, I guess the take-home message is very few studies. There's little research on anticonvulsants, and most of the research has been done in epilepsy because that's their indication is for epilepsy primarily, and they're then often used in bipolar disorder. But some evidence of valproate may be impairing. Antipsychotics are often prescribed as well, and they can have negative effects. But again, how do you tease that out from a more severe illness? So if people are experiencing psychosis, then they're more likely to have cognitive impairments anyway. Antidepressants, I would say there's not a lot of evidence for impairment with antidepressants, but again, there's few studies and often they're not prescribed in bipolar disorder, so it's harder to study. Sedatives, we know definitely can impair cognition. So benzodiazepines have very impairing effects on cognitive function. So there's the evidence around sedatives is much more stronger, and so people are encouraged as much as possible not to be on things like benzos for long periods of time. But probably what the most consistent finding is polypharmacy. So studies have shown that the more medications that people are on, so the higher the number of medications, the more likely there is to be cognitive impairment. But as I said again, it's really difficult to disentangle the effect of the medication from the natural course of the illness. So people who have a more severe illness are more likely to be on more medication and a higher number of medications. And so how do you know, is it the medication causing the cognitive impairment, or do they have more cognitive impairment because they have a more severe illness? So that's still an open question. This was an older study which reviewed, so it's 2010, but I still think it applies today, where they just provided a bit of a summary of the potential mechanisms for the impact of medications on neurocognition or cognitive function. And I've sort of covered off some of those already, and I won't go into too much detail, but like I said, I'm happy to share my slides so you can look at this in a bit more detail. I just wanted to finish the second last slide. Somebody reached out to me and wanted to tell me about their experience, and they said they were happy for me to share this quote with people. As a person diagnosed with bipolar disorder in 2003, had depression since I was in my teens and hypomanic episodes since grad school, I agree with the neuroprogressive theory of the disorder. Since graduate school, I have had a substantial diminishment in cognitive functions, especially cognitive flexibility, and I am no longer able to perform in my chosen career. As of 10 years ago, I also lost 20 IQ points and may have lost additional cognitive reserve since. My cognition is also subjective to mood symptoms, better when hypermanic, and symptoms from my comorbid conditions like my anxiety and PTSD. I believe, in concert with my bipolar disorder diagnosis, complex trauma since childhood also affects my cognition, as it has my brother's who struggles with depression. We have both achieved significantly less than expected based on our childhood IQs. So I wanted to share this with you because it really does encapsulate the complexity of the different impacts on cognitive functioning and the individual experience, and how variable it is from person to person. And you can see this person has really described so many factors which they feel are impacting on their cognitive functioning that are sort of separate to bipolar disorder, that are other things as well, other mental health challenges, and even the impact of different mood episodes. Excuse me. So this is someone who really feels like that they started out with a really strong IQ early in life, and that over time that's really diminished. And so this is kind of going against what those meta-analyses are saying. So, but again, this person is reflecting on their life over a very long period of time, and the longitudinal studies really don't capture that long period, and also don't capture all the factors that this person is describing here. So I keep that in my mind, that, you know, like I said earlier, it's an interplay between people's experiences and what the research shows, and we need to be able to drill down and understand the complexities further. So final slide, my take-home messages. Understanding cognition is complex. Many factors may be at play. Studies of groups of people with bipolar disorder provide a general guide, but in the end, each person's experience will be unique. If you are worried about cognition, please seek advice from your health professional. So you can ask for a cognitive screening or a cognitive assessment. You can ask for it to be monitored over time, to see, you know, maybe to provide you with a bit of objective feedback if you're not sure whether your perception is, you know, if you want to check your own perception and see whether is on testing, is that actually what's happening? And there are also strategies that can be implemented and treatments for cognitive function as well. Today I don't have time to go into that, but yeah, that there's it doesn't mean nothing can be done about it. So I think I'll stop there. Thank you, everybody, for listening. Should I stop sharing the screen, do you think? I think so there's my if you're on Twitter, I have a Twitter account, and my email. You're welcome to email me as well.
Thank you.
Thank you.
Okay, I'll stop sharing so we can see each other.
Does anyone have any questions? I've got everyone muted. Any questions?
I've got to say, Dr. Allott did an amazing job. I understood it, and I really don't have questions. She answered the ones about medication, which were really of import to me.
Mm.
No one?
I'm really interested in people's experiences. I was really excited to present today because I want to understand, you know, obviously talking to people who it impacts is most important. Does what I presented resonate with people? Was it surprising? Is it different to your own experience? I'm really interested in that.
I feel like I learned a lot about the selective impairment, because that's where I feel like I am. I feel like some of my cognitive problems have some things have been a problem increasing over time. I've had bipolar disorder for 40 years, and I'm in my mid 50s now, and was diagnosed in my 20s, but I've had it since I was about 13. So I have a long history of this, and I've been on most of the medications, and I'm suddenly finding myself having a lot of trouble with one of the antipsychotics that knocks my brain completely offline I took it for 6 days and I was out for 3 weeks mentally.
Yeah.
And this isn't just me saying this is my husband. And it's almost become a joke at my house when I take the Abilify, he has to babysit. So while I've had a general slide in my cognition, there's a huge spike in problems when I have to take Abilify. So it's very complicated, and I'm just
I
trying
can
to
definitely say.
work this out.
It is complicated, and I think I said Denise earlier, but Chris, you said you were going to see and I think that's a really important discussion to have. And if there are other antipsychotics that might be better for your cognition, because antipsychotics do affect people differently. Different ones affect people differently. It's very common for people. They do not, like, people describe feeling like a zombie and just really slowed down, and their thinking is just I mean, it dampens everything down, and
I had the same experience with lithium. It was wonderful for stopping my symptoms, just like Abilify is, but it caused so many cognitive problems. And once I was off it, it was fine. I went back to a fairly high IQ, and my brain functioned again. So
yeah, and I think in the research we don't capture those fluctuations. So as I presented again, we sort of think of it as a linear thing, but it's not necessarily. And I think you've kind of really highlighted that. And then certainly the young people that I've worked with who've had bipolar disorder, it's been really interesting where it's been up and down. Like, it sort of would go down and be sort of, their cognitive functioning would be poorer after an episode, but then there'd be a period of recovery and it would sort of come good again. And so it wasn't necessarily a linear thing. It was, and it depends. So it really does depend when people are assessed to know what's exactly going on. So I think that's a really important point. And also taking into account what medications are they on at the time.
Yeah. I was also surprised to learn that the mania, hypomania were the only indicators of difference, and it wasn't depression. It wasn't depressive episodes.
Me too. That surprised me as well, because what people have qualitatively told me is it's the other way around. And I can see Desiree's asked about why hypomanic. So I should clarify, Desiree, it's the way I've written it, it's either hypomanic or manic. So both of those combined, so experiencing manic or hypomanic episodes was found to be more detrimental for people in terms of their cognition. Whereas the number of depression episodes was not related to the course of cognition over the 5 years. So I find that really curious as well. But again, it's really the first study to look at this. We need to replicate. We need more research. You probably get sick of hearing that. Even as a researcher, I get sick of hearing that. I'm like, oh, we got to do more research because it's really complicated.
I noticed that Depakote can be impairing over a long period of time, but lithium is more neuroprotective. My husband had pharmacogenetic testing which indicated lithium wasn't as effective for him as Depakote. And in experience, that's been true. He does better on Depakote. So it feels a bit like a catch-22.
Mm.
The medication that helps you function in day to day could be impairing over the long term. Is that what I'm understanding?
Sorry, Denise, can you say that again?
Well, the medication that is more helpful day to day now could be impairing over a long period of time.
Yeah, and we don't know the answer to that. I know, I mean, the most research I've done in terms of medication has actually been in psychosis, because most of my research is in people with psychosis, not so much bipolar disorder. And the research that's coming out now is suggesting that over time, antipsychotics might be detrimental to cognition, and also people's functioning. But we do need more controlled studies. Probably the best type of research is called a randomized controlled trial. And that's where people are randomly prescribed one medication. One group is prescribed one medication and one is prescribed another, and then they're monitored over time. But those studies are incredibly hard to do, because, as you say, as you've all pointed out, people respond differently to different medications. And so what happens is people get enrolled in those studies, but then a lot changes. They don't stay in those treatment arms because either they've had side effects or they have a relapse, and so then it's really hard to tease out the effects of the different medications in a head-to-head comparison. But that's the type of research we need more of. So we did a study. My PhD student did a study comparing quetiapine with lithium in the first year following a first episode of mania. It was sort of psychotic mania. So all the young people who'd had mania also had psychotic symptoms, but they had a diagnosis of bipolar disorder. And she looked at cognition at baseline before they were randomized to lithium or quetiapine, and then a year later. And the lithium group, there was no difference in the cognitive outcomes at 1 year comparing quetiapine with lithium, but the lithium group, on most domains, but the lithium group had better verbal fluency than the quetiapine group. So their ability to freely recall words and speak in a fluid kind of way was better in the lithium group than it was in the quetiapine group. But, these studies are pretty rare, like it's very hard to do, but that's what you need to understand the effects of the medications more clearly.
So were you saying that the ones on Seroquel did worse than the ones in lithium?
Only in verbal fluency. All other cognitive domains were the same across the groups.
Okay, I understand.
Yeah.
Thank you.
This is her husband. I'm also on Seroquel, so that's a bit of a concern. Valproate, as well as Seroquel, and then Wellbutrin as a antidepressant. So kind of a difficult cocktail.
Yeah, yep. And as I think we said earlier, the more medications you're on, the more effects potentially, but at the same time, it's balancing that with keeping you well.
It really has. Mark got a master's degree and worked in computer science at IBM for 30 years. So he wasn't diagnosed till later in life. And he still is pretty functional as retired.
And I saw Sam has described their experience, who had a delay in their program at school. So yeah, the impact on functioning, there's a lot of research coming out now showing that cognitive difficulties really do predict how people function in day-to-day life. So the more cognitive difficulties, the harder it is to just get on with life and do what you want to do. Perform roles that are meaningful to you, and whether that's school or work or volunteering or leisure activities, social activities. And that's where the impact is really felt for people.
Did we have any more questions or comments?
I was gonna say that my experience has been like the one that was quoted. I was diagnosed in 2002, and my cognitive function has declined to the point where I was teaching for 10 years, and I can no longer teach because I can't maintain the cognitive abilities to teach. I'm trying to go back to substitute teaching, and that's even hard. And on top of that, I did some ECT treatments, which compounded whatever the illness, because I had a lot of manic psychotic episodes, one after another.
I'm sorry to hear that, Katie. That's hard.
And I like the lady that was quoted. I had a very high IQ, and now my IQ has taken a really big hit.
And that's what I say, like what I hear. I guess I'm surprised by what the reviews are showing versus what people are telling me. There's a bit of a disconnect there for some, not for everybody, but yeah, so that's why we do need to understand. And I think there are a subgroup of people, at least, who do experience that decline and has a really great impact on their life. Whether that, I don't know. Do you feel like, Katie, it's getting worse and worse, or it kind of took a hit and then it stayed bad? Like, what's that pattern like?
It took a hit and it stayed bad. And I think I'm now leveling out. I'm getting to the point where I'm euthymic, and I'm hoping that it gets better. I'm hoping from my point, all I could go is up.
Yeah, it's a great attitude to have, and I think, the only thing I would say is slow and steady wins the race. So just re-engaging in things, not trying to do too much, but starting to challenge your brain again, even though it's really a lot harder than it used to be. If you can do that, a bit like going to the gym where we exercise our muscles, and the brain's a bit like a muscle in that way as well. And at the moment it feels like it's weakened for you. But whether there's a way that you can start to just take it slowly and re-engage in some things that challenge your brain a little bit.
I read a book.
Yeah.
I was able to read a book where I wasn't able to read a book. So I think
great.
Better.
It's a good start. Yeah. Oh, I really hope for you that you notice it once you've have that illness under control, as you say, that things start to improve in other areas as well. Desiree was asking about why hypomania and mania is harder or worse has a greater impact on cognitive function. I don't know. So the authors didn't actually speculate as to why that might be in that paper. And I don't know the biology behind it. So I think it's a watch this space. I'm not really sure. You might have heard of theories around inflammation and whether there are inflammatory processes happening, but I don't know why that would be more in hypomania or mania than depression, because we know that's the case in depression as well. So I really don't know. It's a curious one. And like I said, that needs to be replicated, because maybe the next study that tests it finds the opposite. We don't know.
Were there any more questions?
I noticed yeah, Kat, I've got one. Well, not so much a question as a comment. I noticed that when I was taking the valproic acid, I was really as dumb as a post. I had a hard time thinking. I had a hard time getting my words out. And now I've been off it for like 3 months. Thank goodness I'm starting to get some of it back. But I don't find that Abilify was as hard as the valproic acid was.
Mm. Yeah, interesting. Yeah.
Is there any evidence to suggest that?
I'm not sure. Shauna, is it Shauna?
Okay.
Yeah, I'm not sure. I don't know.
Yep,
There's
Shauna.
probably, yeah, I'm not sure. I'm not totally across all of the literature on medication. I've just given you a bit of a high level summary from some reviews, but I don't know. I'm not sure.
Yeah. Okay. Well, thank you anyway.
Yeah.
Last questions? Anyone have any last
No, I'm good.
questions? Well, thank you, Dr. Allott.
My pleasure, Katrin. Should I just email you the slides and then you can share them with people, or?
That would be wonderful.
Yeah, and people can feel free to reach out to me if they're interested in any of the papers or they want to read a bit more, let me know and I can forward things on to you. But it's just, yeah, I've really enjoyed presenting and I'd like to hear from people from their own experience. It's really different to presenting to other researchers and kind of more rewarding, I would say.
Thank you so much.
We have a lot of immediate use for this information, and it's
Right.
really comforting to know that there's somebody out there who's looking at this and trying to improve our situation.
Oh, absolutely. Yeah. I wish there was
Thank you
more
very
of us.
much.
My pleasure. Okay, well, everybody have a good I assume for most of you it's evening. Although there was somebody in Europe. Stefan, what time is it there for you?
He's in
It's
Scotland.
12 in the AM.
Oh, wow, that's commitment. Well, thank you for being here. All right,
Thank you.
Katrin, I'll send the slides through, Katrin. Thank you for inviting me.
Thank you. You have a wonderful day.
Thank you so much.
Thank you
My
so much.
pleasure.
Thanks
Bye,
for
everyone.
coming. We really appreciate it.
Bye.
Bye.
Bye.